I want to give Charles a proper introduction. So Charles Senteio is a colleague of mine. I'm very honored to say he is a colleague of mine in the School of Communication Information and in the Department of Library and Information Science at Rutgers. He is a health informatics researcher focused on improving chronic disease outcomes for underserved populations. Oh, and I also want to mention, there are a few of you on this call, Charles is also the MIT Martin Luther King visiting scholar for the 2020-2021 academic year. Charles's community-based research endeavors really focus on addressing persistent healthcare disparities. He's done so much amazing funded work on HIV, diabetes, hypertension, chronic kidney disease, breast and prostate cancer. He has done research, collaborative community-based research in Flint, Michigan, Detroit, Dallas, and Central New Jersey. And he's particularly interested in using both existing and emerging technology to support underserved patients, which include, the formerly incarcerated and low socioeconomic status urban population. So I've really been trying to get Charles on the schedule to speak about his important work since we started this group back in April. I think he's doing, absolutely crucial and groundbreaking work, and is absolutely sort of tied into the questions of, disparities in the politics of knowledge that we really are hoping to get at with our working group. So today I'm really pleased to welcome Charles to give his talk. The talk is Vaccines Don't Make Us Safe, Vaccinations Do. And he'll be talking about how misinformation helps inflame centuries of mistrust among racial minority groups, which may reduce the intent to receive a COVID-19 vaccine. I'd love everybody to give Charles a big round of applause. We're so excited to have him talking to us. We won't be able to hear it, but I will go ahead and turn it over. Oh, I also want to say, hold your questions or put them in the chat, and then we'll introduce them in the Q&A. So welcome, Charles. So excited to have you.
Thank you. Thanks for the wonderful introduction. I'm going to share my screen here. Hopefully you can all see the slides, or is the slide. Wonderful. Well, thank you, Sushi and Britt, for this opportunity, and I'm looking forward to a lively discussion. Today, I'd like to discuss a contemporary issue. A majority of the population needs to be vaccinated, but generally, we don't trust vaccines, and our ability to stop the pandemic is dependent on two factors: how many of us get vaccinated and the efficacy of the vaccine. So researchers at CUNY ran models based on several factors, like number infected, to determine how effective the vaccine needs to be in order to prevent spread absent physical distancing and mask use, which is, of course, is our goal, so that we can be around each other physically. The model indicated that when vaccination coverage is 100%, meaning when everyone is vaccinated, the vaccine efficiency would need to be 60%. And when vaccination coverage is 75%, vaccine efficiency must be 70%. When coverage is 60%, efficacy must be between 75 and 80%. And this makes sense intuitively. The smaller the proportion of people who are vaccinated, the more effective the vaccine needs to be. But when coverage drops to 50%, it is no longer possible to eliminate the peak, even when vaccine efficacy is 100%. So what that means is half of us must be vaccinated. Black and brown people are more at risk for COVID infection and mortality, and they tend to have higher levels of medical mistrust, which we know influences vaccine uptake. People of color are now and will continue to be at higher risk of COVID transmission and mortality due to social factors like existing morbidity, environmental disparities such as air quality, and living arrangements like multi-generational people living together or living together with multi-generations. Also, disproportionate representation as essential workers is a factor. So 20% of US counties are disproportionately Black, and they account for 52% of COVID-19 diagnoses and 58% of COVID deaths nationally. In New York City, Blacks are 22% of the population and represent 28% of the deaths due to COVID. In New York State, Blacks are 9% of the population and comprise 18% of the deaths. We observe similar patterns in disparities across the US in smaller cities and in rural counties. For example, in Milwaukee, Blacks are 26% of the population, yet account for 73% of the COVID-19 deaths. And in Dougherty County, Georgia, which is 69% Black, Blacks comprised 81% of the 38 COVID deaths. From this paper and the conclusions, social conditions, structural racism, and other factors elevate risk for COVID-19 diagnosis and death in Black communities. Let's focus on what I think is a looming issue. Hesitancy, lack of confidence, and mistrust may dissuade individuals from getting vaccinated once they become available. And we may see racial disparities for vaccine uptake. Pre-COVID, flu vaccine research and uptake around flu vaccines describes the greater hesitancy for vaccines in general, as well as flu vaccines, which is associated with lower vaccine uptake. Greater confidence and trust was associated with higher vaccine uptake. These circumstances represent where multidisciplines can collaborate to go beyond simply describing where health inequities exist. I submit that current times necessitate an urgency to understand why racial inequities exist, and more importantly, what we should try to do to reduce them and mitigate their negative effects. I'd like to use our current circumstances to prompt us to progress beyond simply reporting inequity, but to address the causes and squash them. Perhaps the pandemic and summer wave of racial reconciliation triggered by the Floyd murder has provided the requisite energy to do just that. I'm hopeful. For doing so will help us all rationalize to subsequent generations what we learned from 200,000 plus Americans who have died and 1 million people around the world and counting. As I've grappled personally with these issues in the context of my own community health informatics equity work, my foci has narrowed a bit to mistrust, specifically medical mistrust. No surprise that there's ample literature describing that Black and brown people have disparate levels of medical mistrust when compared to non-minority groups. But there's surprisingly little research that describes pathways from medical mistrust to health behavior and health outcomes. I really dig the title of this paper. It has ubiquitous yet unclear. This particular systematic review found what others have found. There is need for future studies to investigate effects of medical mistrust. Qualitative studies in particular are needed to provide more complete descriptions. And quantitative studies are needed in order to analyze the complex relationships between medical mistrust, health behavior, and health outcomes. This new knowledge is vital, especially now. How do we get here? I'd like to provide some context for how we got here. The answer is fairly simple and probably not surprising. Structural racism, right back to slavery, which of course was rooted in white supremacy. We're probably all familiar with the Tuskegee experiment, at least at a cursory level, which was funded and conducted by the US Public Health Service from 1932 to 1972. It became infamous in the 1940s when penicillin became widely available and was used to treat syphilis, but not for the infected Black men in this study. But let's be clear. What I call racist medical malfeasance did not start with Tuskegee, nor did it end with it. Racism has been a part of medical research as long as there's been medical research. Several important texts outline just that. In some ways, engrave an utterly heartbreaking detail of our sordid past. Any discussion about contemporary racial inequity and levels of medical mistrust is incomplete without acknowledging our past, because those of us who don't understand our history are punished by it. We must be aware of this history so we can understand its lasting influence, and we can develop strategies to appreciate its impact and mitigate its lingering negative effects. I'd like us to consider Anarcha Westcott and Lucy and Betsy, who are peeking around the sheet in this illustration. And of course, Dr. Marion Sims, who's on the far right. He has been affectionately referred to as the father of modern gynecology. Dr. Sims perfected the surgical technique of operating on fistula tears between the vagina and bladder or rectum, which can occur during childbirth, and if left untreated, can cause massive infections leading to death post-birth for women. Sims is also credited with the invention of a surgical examination tool, a speculum, which he first designed and is named after him because versions of it are still in use today. Sims performed experiments on 12 slave women between 1845 and 49. He only mentions 3 by name in his research: Anarcha, Lucy, and Betsy. Even then, medical science experimental surgery was performed on cadavers or under proper conditions. But Sims performed his experimental surgeries in his backyard in Alabama without the use of anesthetics, which at the time were available. I spent a lot of time with this illustration, especially when I consider drivers of health behavior and mistrust. Racial differences in health are present at the very inception of health records being kept in the US. Up until and through the Civil War, physicians debated whether the already well-known racial disparities in health were due to biology, because Blacks were inferior, or social factors, because many Blacks were enslaved and all lived in a society steeped in white supremacy, one in which Black bodies, minds, souls, and spirits just didn't matter as much as white people's. At the time, the debate was deeply rooted in politics, as anti-slavery physicians, which included the first generation of Black doctors, argued that social factors were the drivers. These social factors were, at the time, defined by the need for cheap labor, and those conditions were what determined both the progression of disease and the health status of enslaved Blacks in the South and impoverished Blacks in the North. Dr. Knott was a Southern gentleman, and as a slave owner, so as you might guess, he represented the biology side. So misinformation on the biology side of scientific truths were informed by biases in the interpretation of the world around them. These existed at the very inception of health research in the United States. Dr. Knott wrote in 1851, "The Negro races stand at the lowest point in the scale of human beings. It is clear that they are incapable for self-government and that any attempt to improve their conditions is warring against the immutable force of nature." The biology versus social debate about the explanation for racial health disparities persisted until W.E.B. Du Bois' seminal work in 1899, The Philadelphia Negro. In it, Du Bois contrasted the biological point of view and his observation that social advancements and vastly different living conditions or different conditions under which Blacks lived were the drivers of racial health disparities. Du Bois, the sociologist, argued that although the causes of racial differences in health were multifactorial, they were primarily social. I submit that Du Bois is as significant to health equity research as the London physician John Snow is to public health. As many of you know, Snow's research found that cholera was spreading through contaminated water, which conflicted with the version of the scientific truth at the time, which was that cholera spread through air. Another example of how science hadn't reconciled the truth quite yet. But Du Bois went further in making the argument for social factors. He observed the apathy to the disparities. And at times I think we still don't care quite enough. We still don't behave often enough as if Black and brown lives matter or matters as much as other lives. Du Bois wrote, again in 1899, "The most difficult social problem in the matter of Negro health is in the peculiar attitude of the nation towards the well-being of race. There have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference." We're probably familiar with what Du Bois observed, these social advancements and the vastly different conditions. Du Bois indeed was onto something. We know now that racial inequity and health outcomes are driven by social determinants of health, and inequity has been described for various groups, among them people of color, women, the Appalachian poor, LGBTQ, and prisoners. And these different conditions are observed at the individual level right down to the clinical encounter. Across a broad range of clinical settings, patients of color are treated negatively due to race. For example, in ERs across the United States, research describes how Black and Hispanic patients are less likely than white patients to receive pain medication for acute pain. Also, Black patients are more likely to believe that they are treated differently due to internalized and institutional racism. In the primary care setting, Black diabetes patients are more likely to believe that physicians discriminate against them, and physicians may harbor biases that they believe make physicians less likely to share test results with them and more likely to be dominant and overbearing when talking to them. As a result, Black patients are less likely to share health information and are less likely to follow physician recommendations. Finally, the 2005 documentary film No Mas Bebes documented a landmark event in reproductive justice when a small group of Mexican immigrant women sued LA County doctors, the state of California, and the US government. They claimed that they were sterilized without their consent while giving birth at the LA County USC Medical Center during the late 60s and early 70s. They claimed that they had been coerced into tubal ligation by doctors during the late stages of labor. It was not disputed that often the procedures were performed after asking the mothers when they were under duress. Despite the judge ultimately ruling in favor of the hospital, specifying in part that there was no deliberate intent of the doctors to hurt the women, the case prompted changes in hospital procedures regarding sterilization. For example, consent forms are now made available in different languages, including Spanish, and patients under 21 have 72 hours to make this decision. In considering the sources and effect of misinformation, which of course is false or inaccurate information deliberately intended to deceive, context matters. We information scientists know that we humans process information in social, organizational, and individual contexts. So a phenomenon like mistrust must be considered in these contexts. It can be an elusive construct to study, especially when trying to describe pathways from medical mistrust to health behaviors to health outcomes. We are all probably familiar with the common sources of information, especially during these times. I found this recent series of New York Times stories most interesting as I prepared for this talk. Now, we have to ask just as much we can of public health officials. How much faith do we have in government-run institutions who were for years the international gold standard for providing authoritative, science-based public health guidance? The current administration has attempted to co-opt the CDC and the FDA brands in particular. How might this compromise their reputation, authority, and credibility? And what does this mean to getting Americans vaccinated? Brands are about trust, and trust is built in drops and lost in buckets. Even the universally respected Dr. Fauci has been drawn into the fray. So what are the implications? A recent Kaiser poll shows that we are losing confidence in the FDA, CDC, and NIH. Our levels of trust concerning COVID vaccines in particular seem to be associated with the upcoming election. And of course, politics again drives misinformation, just as it did before, during, and after the Civil War. Of course, these polls may change daily, and who knows what they may look like after the election, or perhaps more importantly, after election results. And then when a vaccine becomes widely available. But a central point here is that perceptions are important because confidence in the importance of vaccines, rather than their safety or effectiveness, has the strongest association with vaccine uptake. And around the world, we see growing evidence of intent to delay or refuse a vaccine due to lack of trust in the importance, safety, or effectiveness of them. This study was published on September 10th. It maps perceptions across 149 countries between 2015 and 2019. Back to race. Alongside other inequities, lack of diversity of clinical trials is a persistent reality. For example, for all clinical trials for cancer drugs for FDA approval from 2010 through 16, 82% of participants were white, 10% Asian, 4% Hispanic, and 2.3 participants were Black. This reflects global cancer clinical drug trial racial inequity, in which 2.6 participants are Black. Black participation in all US-based clinical trials has held steady at about 5% for many years now. The impact of this disparity is exacerbated by urgency to create a safe and effective vaccine. So as you might imagine, there is also lack of diversity in COVID vaccine clinical trials. And while this has been reported as an issue, there is comparatively less research and other information for how to recruit Black and brown research subjects. Moderna reported that 28% of its participants in its COVID-19 vaccine clinical trials were from racial minority groups. This is historically high, but given the disproportionality of infection and mortality, it's still insufficient. From the story, having sufficient participants among Black and Hispanic people in particular is crucial in obtaining statistically representative results for these communities that have been disproportionately hit by the pandemic. Scientific discovery is messy. It's sort of like democracy, messy, slow, cumbersome. If you want speedy government, you'll need to refer to monarchies or dictatorships. Scientific discovery is similarly messy. We scientists argue quite a bit about what facts are and how we arrive at them. Skepticism and doubt is woven into the warp and woof of the scientific process. Both bench and social scientists participate and agree to these norms. We like to argue, but we love to critique someone else's proposed discovery of truth. That was moving along kind of okay, far beyond public view, until COVID-19. Now, scientific discovery in the age of COVID is breaking news. Not only are health disparities kitchen table topics, but week to week and day-to-day updates on clinical trials are now breaking news on nightly broadcasts. I used to use PubMed for my alerts for new literature. Now, Wolf provides me with my updates. Now, if only CNN had a citation tools button so I can more easily cite Wolf. See, if we were in the same room, I'd be able to tell if that attempt at levity was effective. Oh well, we'll just have to wait until the chat. This is from a story from Mother Jones at the end of April. What was once a marathon has been compressed to a 400-meter dash. Researchers race to deliver results. Academic journals race to publish, and the media races to bring new information to a scared and eager public. There has been an escalating critique of the rush to publication and short-circuiting of the peer review process. So our hallowed top journals seem to be creeping towards responding to the news cycle, and the public is noticing. From the Washington Post from May, faith in medicine and science is based on trust, but today, in the rush to share scientific progress in combating COVID, that trust is being undermined. Over the last several months, journals have sped up time from submission to publication. Literally thousands of papers have been published as open access preprints, bypassing the peer review process. The publication Retraction Watch has been tracking notices of retractions and expressions of concern about COVID-related research. During the first week of June, at least 3 major medical journals retracted published studies. Here's a paper. Against Pandemic Research Exceptionalism, published in Science in May, on May 1st, actually. It argues for the need for scientists to collaborate. It emphasizes that while rigorous research practices can't eliminate uncertainty, they represent the most efficient way to clarify causal relationships. From the paper, Good science is hard to do. And in an outbreak, there's a tendency to say more science is better than none. In closing, I'll offer my suggestions as we move forward in this ever more complicated world of misinformation. And we should consider that this is a great moment for us to rethink our assumptions. 2020 equals chaos, which is a great time to reassess everything because much of what we thought we knew has been shattered. Let's rethink how we rank the importance of facts. We scientists tend to lean too heavily on facts. They certainly matter and are a guidepost, but for our work to influence populations, we must look around. The world is responding to narratives, and we do too. Know why? Because we're human. We still love stories. And Brown, the social work researchers, transformative research has been trying to teach us this. So I suggest we try to use stories more as we discover new knowledge and disseminate it to inform and try to influence those around us. Let's get better at telling stories because in these times we know that stories are greater than facts. Let's convey our facts as stories. There's plenty of stuff online that helps us do just that, but the details for that are for another talk. Let's go back to Anarcha and Dr. Sims. What story would we tell Anarcha's descendants about COVID-19 and vaccines? What will we tell Dr. Sims' descendants? After all, that legacy is still with them as it is with all of us, albeit for most of us unconsciously. I submit that our lived experiences, which influence mistrust, are informed by the generations between ours and Anarcha and Dr. Sims. In this context, what story do we need to tell and how do we need to tell it? Let me just reshare the slides for a moment because I see that they went away. Okay, can we see the slides now?
Yes.
All right. I have some good news. Our disciplines have already described great insights, some great tips. How can we help communicate information concerning what we know and what we don't know about vaccines? How can we get others to trust us when we have to say, I don't know? Well, as COVID has taught us, the public can have a mighty thirst for scientific discovery. We are all too often eager to answer them. Well, the sheer unknown should humble us. And we need to get more comfortable with simply saying, I don't know. Perhaps we should consider this response. We don't know yet. We have literature that helps us recognize the human factors in communicating information about future COVID vaccines. We should draw upon insights from health informatics and other social, behavioral, and communication sciences in particular for how to advance public understanding of vaccines. There are communication strategies we can consult to get information to people about future vaccines. Here's a Rutgers School of Environmental and Biological Sciences, or SEBS, site, which lays out what we already know about how to create effective campaigns in this context. It includes, is everyone seeing my screen?
Not anymore.
Let me share again for some reason. All right, we're good now? All right, thank you. It includes, we need to understand the reasoning behind people's decisions to act a certain way, and we need to start with their beliefs, not ours. So we must go to Anarcha and Dr. Sims' descendants and meet them where they are. Initiate and nurture a relationship with them so they'll trust us enough to tell us what they think and what they feel and why. So they'll gain confidence in us when we disclose that we don't know yet. A couple of years ago, I was preparing a health equity lecture to Rutgers nursing students in a health informatics course. As I was preparing, I asked one of my nurse buddies for tips on what I would share with them. She told me to tell them to go to the Genba, which is a Japanese term meaning the actual place. Let's go to the Genba to listen and apply our frameworks, theories, models, and experiences in service to those we purport to support. Let's also be open to having them teach us and move us. We health researchers are plagued by a fundamental challenge. Our daily lives are so divergent from the lives of those we are efforting to support. Our context for health information, our trips to the doctor, and what happens when we get there may be more distant than we appreciate. This is not about guilt or gotchas, or our new commitment should be to the dignity of all people and make sure that they can live lives of decency. Health equity work is fundamentally about striving for fairness. It's about our responsibility as those in power to work to make this a reality. Thank you, and I look forward to your questions and comments.
Thanks so much, Charles. That was great.